I will start off with a case scenario. So here we have a 20-year-old female whose main concern is unwanted facial hair. She had menarche at 14 years of age. Since then, she's been having irregular periods, acne, and hirsutism. There's no virilization. BMI is within normal limits. No features of Cushing syndrome. FSH, LH, TSH, and prolactin levels are within normal limits. Testosterone level is slightly raised. Ultrasound shows evidence of polycystic ovaries. Early morning 17-hydroxyprogesterone level is raised. So this clinical picture suggests the diagnosis of congenital adrenal hyperplasia. 17-OHP is sort of indeterminate range. So stimulated 17-OHP in this patient was above the cutoff for diagnosis of CAH. So this patient's clinical picture suggests a diagnosis of non-classic CAH. CAH is a group of genetic diseases inherited autosomal recessively, and it's due to a deficiency of one of the enzymes involved in adrenocortical steroid biosynthesis pathway. And the commonest form, which is seen in more than 95% of the cases, is due to 21-hydroxylase deficiency. So in my talk, I'm mainly talking about 21-hydroxylase deficiency. So here, when the 21-hydroxylase is deficient, the production of aldosterone and cortisol is blocked, and the precursors are diverted into sex hormone biosynthesis. So you will get excessive androgens, reduced level of mineralocorticoids and glucocorticoids. When the cortisol is low, the ACTH secretion is stimulated, which causes adrenal hyperplasia. So the phenotype depends on the severity of deficiency of the 21-hydroxylase levels. So mild form, what we call non-classic hyperplasia, can sometimes be asymptomatic with normal fertility, or it can present usually during adolescent period or adulthood with features of androgen excess. The severe form is classic CAH, which can be again divided into salt wasting and simple virilizing forms. Usually the diagnosis is made during infancy, and the affected females are having virilization, and in salt wasting form, the infants can develop adrenal crisis. So how do we diagnose? The diagnostic test is 17-OHP, which should be done early morning before 8 a.m. And in a menstruating female, this should be tested during follicular phase, because in the luteal phase, we have raised progesterone levels. The best assay is mass spectrometry. And if the menstrual cycles are irregular, you can do this test at any time. So these are the cutoff levels for 17-hydroxy-OHP for diagnosis of CAH, recommended by the American Endocrine Society 2018 guideline. So if the level is more than 30 nanomoles per liter, the baseline 17-OHP, you can make the diagnosis. If it is below 6, you can exclude the diagnosis. If it is indeterminate, you have to go for the stimulation test. So when we do the co-syntropin test, what we do is we take blood for baseline 17-OHP and ideally cortisol, and then we give 0.25 milligram of synacthen and test 17-OHP and cortisol levels after 1 hour. So if the level is above 30 nanomoles per liter, you can confirm diagnosis of CAH. So going back to the patient, in this patient, the main concern is androgen excess, features due to androgen excess. So even in non-classic CAH, if there is patient-important hyperandrogenism, it should be treated with steroids. So we need to optimize glucocorticoid dose. In adults, we can use hydrocortisone as well as long-acting glucocorticoids like prednisolone or even dexamethasone. So our aim is to keep 17-hydroxyprogesterone levels slightly raised. We should not normalize it, because normalization usually indicates overtreatment with the steroids. Serum androstenedione level is again a good marker of disease control, and the aim is to keep it within the normal range. In addition to steroids, to manage hyperandrogenism, you can use oral contraceptive pills, preferably one with progesterone, which has anti-androgenic actions like drospirenone or cyproterone acetate. Anti-androgens can be used like a spironolactone. However, if you are using spironolactone in a female, you need to educate them about teratogenicity, and also in salt wasting form of classic CAH, spironolactone should not be used because we know it's a mineralocorticoid receptor antagonist which can cause volume depletion. So a bit about classic CAH. So we need to replace the deficient hormones, glucocorticoids and mineralocorticoids. We can use hydrocortisone or prednisolone along with fluorocortisone. So it's very important to take measures to prevent adrenal crisis in this population. Here the commonest cause of death, one of the commonest cause of death is adrenal crisis. So we need to educate the patients about the importance of treatment compliance. We need to educate them about sick day rules, importance of wearing medical identification on hyperadrenalism, and if available, they should be provided with glucocorticoid injection kit. So infertility is one of the major problems in adults. It's usually multifactorial. Raised androgen levels and progesterone can interfere with follicular genesis and maturation of the endometrium. And in those who had classic CAH and has undergone surgery, mechanical problems like vaginal stenosis and also a small introitus causing dyspareunia are problems. And so these patients can have several sexual and psychosocial problems. So how do we treat? We need to optimize glucocorticoid treatment. And here our aim is to keep follicular phase progesterone levels below 2 nanomoles per liter, and this usually requires increasing dose of steroids. And this, we need a multidisciplinary team to manage this sort of patients, especially if there's a history of pelvic surgery in the past. The pelvis should be assessed by the gynecology team, and also we need inputs from the fertility specialist to exclude other causes, and these patients might need additional therapy for ovulation induction and IVF. So if your patient wishes to conceive, then it is important to provide genetic counseling. It should be provided to all patients. We need to see whether the partner is a carrier for CAH. In that case, there's a risk of child being affected. So we should avoid dexamethasone during pregnancy because it can traverse the placenta and there are safety issues. Currently, treatment with dexamethasone during pregnancy in order to prevent virilization of affected female fetus is not recommended. So during pregnancy, we know the progesterone level goes up, renin levels goes up, testosterone levels might go up. So we cannot use the other the biochemical parameters to monitor these patients. So we usually go by clinical parameters. We can go by blood pressure, serum electrolytes. So you need to look for symptoms, and we might have to increase their glucocorticoid dose during pregnancy, especially during second and third trimester. So for delivery and labor, we need to give them stress doses of hydrocortisones. And for those who had genital surgery in the past, for them, we might have to go for cesarean section for delivery due to cephalopelvic disproportion sometimes. So newborn screening for CAH is done universally in some countries, but in Sri Lanka we don't have it. So especially in patients with CAH, if following delivery, we need to screen the neonate for CAH. Bit about males. So development of testicular adrenal rest tumors is a problem in males, which is ACTH dependent, and these tumors usually arise close to the reti testis, and they can block the seminiferous tubules, thereby can cause obstructive azoospermia. And sometimes these tumors can induce a fibrotic reaction which can damage the testis. Sometimes the damage can be permanent. So it is very important to screen these patients for TARTs, especially the classic CAH. TARTs in non-classic CAH is rare. So usually it appears during puberty, and then prevalence increases with age. So screening with ultrasound should be started at the age of 10, and thereafter periodic screening should be done. The other problem in males with regard to fertility is suppression of gonadotrophins due to raised progesterone. So the treatment involves optimization of glucocorticoid therapy, and our aim here is to keep their androstenedione levels at a lower level. And the androstenedione to testosterone ratio in males is a good indicator of excess of adrenal androgens. So in eugonadyl men, it is around 0.5, and our aim is to keep androstenedione levels in males to levels which is less than 0.5, less than 50% of their testosterone levels. If there is no good response to steroids, we can consider testicular sperm extraction in patients with TARDs who are having obstructive azoospermia. In young males, we can consider sperm banking to preserve their fertility. How should we monitor these patients? So patients with CAH needs monitoring by a specialist, ideally endocrinologist. They should be assessed at least annually. Annual physical examinations should be done. We need to look for signs of glucocorticoid excess, such as cushingoid features, obesity, hypertension, diabetes, and dyslipidemia. We need to look for signs of mineralocorticoid deficiency or excess. For that, we can check their blood pressure. We can do their plasma renin activity and serum electrolytes. 17-OHP levels should be monitored to monitor their disease control. And in adults, the other problem is long-term complications of long-term steroid use. So we need to counsel these patients about the importance of healthy lifestyle, and our aim is to maintain their BMI within normal range. The other problem is osteoporosis and fractures, especially if they have been on higher than average dose of glucocorticoids for a prolonged period. So in those patients, we need to do a baseline DEXA scan to check their BMD. And of course, we can optimize their bone health by providing calcium and vitamin D supplements and encouraging weight-bearing exercise. So in summary, management of CAH in adults needs inputs from various specialists. So we need a multidisciplinary team approach. And in classic CAH, we need to replace the deficient hormones, glucocorticoids and mineralocorticoids. And it's very important to take measures to prevent adrenal crisis in these patients. And we need to monitor for signs and symptoms of glucocorticoid excess. And we need to control their androgen excess. For that, we usually optimize glucocorticoid dose, and we might have to use OCP and antiandrogens. Fertility and sexual function is a very important problem in adults, and genetic counseling should be offered to all patients, especially if they wish to conceive. Pregnancy, management of pregnancy again needs special care. Dexamethasone should be avoided during pregnancy, and we need to monitor them for steroid side effects. And the patients with CAH is having high risk of developing metabolic syndrome and complications. Therefore, we need to address their metabolic risk. Thank you.